I am Dr. Leana. Welcome to our channel. Today we are talking about 5 medications that can become shockingly dangerous after age 65, even when they seem ordinary, helpful, and completely familiar. You may discover that the pill causing fatigue, confusion, dizziness, bleeding, or a frightening fall is not rare at all. And wait for it, because the most dangerous part is not always the medicine itself. It is how the aging body processes it once it enters your bloodstream. After 65, the rules of medication change, and most people are never clearly told that. The kidneys often clear drugs more slowly. The liver may process them less efficiently. The brain becomes more sensitive to sedating chemicals, and body composition shifts in ways that can make certain medicines stay in the system longer and hit much harder than they did at 50 or even 60. That means a prescription you tolerated for years can suddenly start acting like a different drug. A sleep aid can become a fall risk. An anxiety pill can become a memory problem. A pain reliever can quietly become a bleeding emergency. And the truth is, many older adults never connect the symptom to the medication because the change is gradual, subtle, and easy to mistake for just getting older. But here's the shocking part. The most dangerous medications after 65 are often prescribed for very common problems: pain, anxiety, insomnia, agitation, and diabetes. In other words, the danger is not hiding in some rare specialist-only prescription. It is often sitting in a familiar orange bottle in the kitchen cabinet, beside the vitamins and the blood pressure pills, looking completely harmless. So in this video, I'm going to walk you through the 5 medication categories I worry about most after age 65. Not because every one of them is always wrong. Some have important uses, and sometimes they are absolutely necessary. But they are the medications that deserve a second look, a better question, a safer conversation, and in many cases, a smarter plan. And please hear me carefully before we go one step further. Do not stop any prescription suddenly on your own, especially medicines for anxiety, sleep, psychosis, pain, or diabetes. Some of these drugs can cause serious withdrawal, rebound symptoms, or dangerous instability if they are stopped too fast. This video is not about panic. It is about protection, awareness, and knowing which questions could save you from a fall, an ER visit, or something even worse. Now, before I start the countdown, I want to give you one bonus warning that catches a lot of families off guard. It is not always the prescription medication causing the problem. Sometimes it is the over-the-counter PM product, the nighttime cold medicine, or the allergy pill someone takes because it seems gentle, familiar, and easy to buy without a doctor's visit. If you see diphenhydramine or doxylamine on the label, that should make you pause. These drugs are strongly anticholinergic, which means they block acetylcholine, a chemical messenger your brain and body depend on for memory, alertness, bowel function, and bladder function. In younger people, that may cause a little drowsiness. In older adults, it can trigger confusion, constipation, dry mouth, urinary retention, brain fog, and a much higher fall risk. You won't believe how often this gets missed because the medication is sold over the counter. People assume prescription means powerful and non-prescription means safe. But after 65, that assumption can be dangerously wrong. Remember when I mentioned that the aging brain becomes more sensitive? This is exactly what I meant. The same chemical effect that makes a person sleepy can also make them disoriented, unsteady, and much more vulnerable at night. And that leads us into the first medication category on the list, because this one can look like ordinary diabetes control until the moment it becomes a crisis. Number 5 is sulfonylureas, a group of diabetes medications that includes glympyride, glipizide, and glyburide. On paper, these drugs do something helpful. They lower blood sugar by pushing the pancreas to release more insulin. That sounds sensible. But here is the hidden danger. Insulin keeps working whether or not enough food is coming in, and that is where things can go off the rails after 65. Imagine a 76-year-old man who takes his usual diabetes pill in the morning, but that day he is not hungry. Maybe he has a stomach bug. Maybe he skips lunch because he has a doctor's appointment. Maybe his kidneys are not filtering as well as they used to, so the medication lingers longer. By mid-afternoon, he is sweating, shaky, irritable, and confused, and everyone around him thinks he is tired or dehydrated. But here's the shocking part. His brain may actually be starving. The brain depends heavily on glucose for fuel, and when blood sugar drops too low, the brain starts to malfunction. That can look like weakness, blurred vision, sudden fatigue, confusion, trembling, or bizarre behavior. In more serious cases, it can lead to passing out, seizures, coma, and in extreme situations, death. This is one of the reasons low blood sugar can be so dangerous in older adults. It does not always announce itself dramatically. Sometimes it looks like forgetfulness. Sometimes it looks like dizziness. Sometimes it looks like a strange mood change, a fall in the kitchen, or a person who suddenly just doesn't seem right. And because those symptoms are common in aging, the medication can keep getting blamed on everything except the real problem. The truth is, a diabetes medication is not automatically safe just because it lowers blood sugar. The real question is whether it lowers blood sugar safely for that person's age, appetite, kidney function, weight, daily routine, and ability to eat regularly. That is a very different standard, and after 65, that distinction matters more than most patients realize. Longer-acting sulfonylureas can be especially troublesome because the low blood sugar can last longer and be harder to correct. That means one bad episode is not always a quick dip and recovery. It can become hours of confusion, weakness, instability, and real danger. If someone lives alone, the risk becomes even more serious because there may be nobody nearby to recognize what is happening. So here is the practical message. If you or a loved one is on one of these medications, ask whether the treatment goal still fits the person's age and current health. Ask what symptoms of low blood sugar to watch for. Ask whether there is a safer option. And most importantly, do not assume that shakiness, tiredness, or mental fog are simply part of getting older. Sometimes the body is sending an urgent biochemical distress signal. Now let's move to number 4, because this next category hides in plain sight. It helps millions of people feel better quickly. It is taken for arthritis, back pain, joint pain, headaches, and everyday aches, and yet it can quietly injure the very organs older adults depend on most. Number 4 is oral NSAIDs. Medications like ibuprofen, naproxen, meloxicam, diclofenac, indomethacin, and ketorolac. These drugs can absolutely reduce pain and inflammation. That is why they are so popular. But they also block prostaglandins, and prostaglandins do much more than create soreness. They help protect the stomach lining, support blood flow into the kidneys, and influence fluid balance in the body. So when someone takes these medicines repeatedly, especially at older ages, the body can lose some of those protective effects. The stomach lining becomes more vulnerable to irritation and bleeding. The kidneys may receive less supportive blood flow. Blood pressure can rise. Fluid can build up. A person with a touch of heart failure can suddenly worsen. And a medication that started as pain relief can slowly become an internal emergency. Here is a real-world scenario that happens more often than families realize. A 72-year-old woman has knee pain, so she takes ibuprofen every day for months because it is the only thing that helps her move around. She is also on a blood thinner. Then one morning she feels weak, dizzy, and short of breath. She thinks it is exhaustion, but the shocking part is that she may be bleeding internally, one small dose at a time. And this is why NSAIDs are so deceptive. They do not usually create danger in a dramatic Hollywood moment. They often create danger through repetition. One pill for a bad back day may not do major harm, but daily use for weeks, months, or years is a different story, especially in adults over 75, people with kidney disease, people on blood thinners, or people taking steroids or antiplatelet drugs. You also have the problem of doubling up without realizing it. Someone takes naproxen for joint pain, then grabs an over-the-counter cold medicine or another pain reliever without noticing it contains a similar ingredient. Suddenly the dose is higher, the risk is higher, and the body is absorbing far more than the person intended. You won't believe how many medication disasters begin with that exact kind of unintentional stacking. But here's the good news. Pain treatment does not always have to mean chronic oral NSAID use. Sometimes the safer conversation involves topical diclofenac, physical therapy, better footwear, targeted exercise, heat, weight reduction, joint injections, or other pain strategies that reduce whole body exposure. Remember when I mentioned that medication risk after 65 is often about biology and combinations? NSAIDs are a perfect example of both. Now we come to number 3, and this one is especially important because it targets a problem that makes people desperate. When someone is not sleeping, they are tired, anxious, frustrated, and willing to try almost anything. That desperation is exactly why this class becomes so dangerous. Number 3 is the group known as Z drugs, including zolpidem, zaloplan, and azopiclone. These are often seen as gentler or more modern sleep medications, almost like a refined version of older sedatives. But that image is misleading. In older adults, these drugs still act on brain pathways that reduce activity and increase sedation, and the aging brain does not always handle that slowdown gracefully. Here is what makes this so dangerous after 65. The dose is taken at night, when blood pressure may already dip, vision is limited, reaction time is slower, and many seniors are getting up to use the bathroom. So now you have darkness, grogginess, reduced balance, and a sedated brain all happening at the same time. That combination is a setup for a fall, a fracture, or a terrifying trip to the emergency room. Let me paint the picture. A woman in her late 60s takes her sleep medication because she has had 3 bad nights in a row. At 2 in the morning, she wakes up to use the bathroom. She stands too quickly, feels just slightly off, clips the corner of a rug, and falls. She breaks a wrist or a hip, and suddenly, the issue is no longer insomnia. It is surgery, rehab, immobility, fear, and loss of independence. But here's the shocking part. These drugs often provide only modest improvement in how quickly people fall asleep or how long they stay asleep. In other words, the trade-off can be brutally uneven. A person may gain a little more sleep, yet pay for it with more confusion, falls, fractures, emergency room visits, hospitalizations, and next-day impairment. That is not a harmless nighttime helper. That is a major quality-of-life gamble. The truth is, sedation is not the same thing as restorative sleep. You can knock the brain out without actually repairing the underlying sleep problem. And that distinction matters. Because if the real issue is sleep apnea, pain, depression, anxiety, late caffeine, poor sleep timing, nighttime urination, or a noisy sleep environment, a sedative may only cover the symptom while leaving the cause untouched. This is where the phrase, "but I sleep better with it," can become misleading. Better compared to what? Better than lying awake frustrated? Maybe. Better for your brain, balance, memory, and long-term safety. Not necessarily. That is why non-drug treatment like CBTI, sleep scheduling, morning light exposure, reducing evening stimulation, and treating the true cause of insomnia can be far more powerful than people expect. And wait for it, because the next medication category is even more emotionally complicated. Families are often frightened. Caregivers are exhausted. The patient may be agitated, paranoid, or aggressive. Everyone wants relief, and that is exactly why the next drugs can feel like a miracle right before they become a serious mistake. Number 2 is antipsychotics used in older adults with dementia or delirium. Medications such as risperidone, quetiapine, olanzapine, and haloperidol. This is a difficult subject because families are usually dealing with genuine distress. A loved one may be wandering, shouting, hallucinating, or striking out in fear. In that moment, a calming medication can feel less like a prescription and more like a lifeline. But here's the shocking part. In a frail, older brain, especially one affected by dementia or delirium, these drugs can carry very serious risks. Antipsychotics alter major brain signaling systems, particularly dopamine and serotonin. That may reduce severe agitation in some situations, but it can also deepen sedation, worsen movement problems, cloud cognition, and contribute to dangerous drops in blood pressure when a person stands up. And the risk does not stop there. In older adults with dementia-related psychosis, these medications carry a boxed warning because they are associated with increased risk of death. They have also been linked to higher stroke risk and faster cognitive decline in this population. That does not mean they are never used. Sometimes they are used in extreme situations when a person is at risk of harming themselves or others. But these are not convenience drugs. Let that sink in for a moment. A medication given to calm behavior can, in the wrong setting, increase the very risks families are desperate to avoid. That is why the first question should not be, what can sedate them? The better question is, what is causing this behavior? Is it pain? Is it infection? Is it constipation? Is it urinary retention? Is it sleep disruption? Is it fear? Is it the environment? Remember when I mentioned that some symptoms blamed on aging are actually medication-related or biologically triggered? The same principle applies here. Delirium, agitation, and sudden confusion are often signals that something underneath is wrong. When a patient is medicated before the cause is understood, the warning sign gets muffled, but the underlying problem may keep worsening. I want to be very clear, because nuance matters. There are times when antipsychotics are used thoughtfully in severe circumstances, especially when safety is at stake. But routine or casual use for behavior control in older adults with dementia should never be treated lightly. These are high-stakes drugs, and every family deserves a careful discussion about risks, goals, duration, and non-drug alternatives before they become the default answer. And now we arrive at number 1, the category I would urge every senior caregiver, adult child, and even every physician reviewing an older chart to look at with extreme care. Because this next group is common, powerful, deceptively effective at first, and capable of causing serious harm in more than one way. Number 1 is benzodiazepines, medications like alprazolam, lorazepam, clonazepam, diazepam, and temazepam. These drugs are prescribed for anxiety, panic, muscle tension, insomnia, and sometimes other conditions. And here is what makes them so seductive. In the beginning, they often work fast. A person who feels overwhelmed, tense, or frightened may feel relief within a short time. That immediate calm can be incredibly reinforcing, but the truth is, the same mechanism that creates relief can also create the danger. Benzodiazepines strengthen GABA signaling, the brain's main inhibitory brake system. In simple terms, they turn the volume down on brain activity. That can reduce anxiety, but it can also slow reaction time, impair memory, blur thinking, reduce balance, weaken coordination, and increase daytime sedation, especially in older adults whose brains are more sensitive to the drug. Now think about what that means in everyday life. The person takes a pill for anxiety and feels calmer, but they are also driving slower to react, walking less steadily, remembering less clearly, and waking less sharply in the morning. A near fall becomes a fall. A missed step becomes a broken hip. A moment of forgetfulness becomes a pattern the family worries might be dementia when the medication is playing a major role. But here's the shocking part. Many people assume that if they have taken benzodiazepines for years, that proves the medicine is safe for them. In reality, long-term use can be part of the problem. The body adapts. Dependence can develop even when the medication is taken exactly as prescribed. So the person is no longer just taking the drug for relief. They may also be taking it to avoid withdrawal. And withdrawal from benzodiazepines is not trivial. It can cause severe anxiety, shaking, insomnia, agitation, and in serious cases, seizures. That is why these medications should never be stopped suddenly without medical supervision. This is one of the most important warnings in this entire video. If you or someone you love is on one of these drugs, the answer is not abrupt discontinuation. The answer is a careful, medically guided review. Now wait for it, because the most dangerous part may not be the benzodiazepine alone. It may be the combination. When benzodiazepines are taken together with opioids, the risk rises dramatically. Both can suppress the central nervous system. Both can slow breathing. Both can intensify sedation. Put them together in an older adult with frailty, sleep apnea, lung disease, or just a highly sensitive system, and that combination can become life-threatening. This is how a medication for anxiety and a medication for pain can quietly form one of the most dangerous pairs in the medicine cabinet. The person gets more sleepy, less alert, less steady, and less able to respond to breathing problems during sleep. Families may just notice that the person seems unusually drowsy, foggy, or hard to wake. But the real problem may be respiratory depression building underneath the surface. You won't believe how often people think the warning signs are just fatigue or age. They say, he's slowing down, or she's been more forgetful lately, or he's just not himself. And yes, aging changes people. But remember when I mentioned that a medication can imitate aging? Benzodiazepines are one of the best examples. They can mimic cognitive decline, worsen delirium, intensify falls, and rob a person of sharpness they might otherwise still have. So if there is one category on this list that deserves immediate respectful review, this is it. Not fear, not shame, not sudden stopping. Review. Ask why it was started. Ask whether the original reason is still present. Ask whether the dose is still appropriate. Ask whether another sedating medication is also in the picture. And ask whether a slow taper plan, safer treatment, therapy, or alternative strategy could reduce risk without throwing the nervous system into chaos. Now let's step back, because all 5 categories point to the same deeper truth. Medication safety after 65 is not just about the name on the bottle. It is about how the older body handles the drug, how many other medications are present, whether the treatment goal still makes sense, and whether the current risk has quietly become greater than the current benefit. So what should you do next? Bring every medication to a review. Prescriptions, over-the-counter sleep products, allergy pills, pain relievers, supplements, everything. Then ask 5 simple questions. Why am I taking this? Do I still need it? Is this dose right for my age and kidney function? Is there a safer alternative? And could this be interacting with something else that affects my brain, balance, bleeding risk, kidneys, or blood sugar? Those 5 questions can change everything. They can prevent a dangerous low blood sugar episode. They can uncover a hidden bleeding risk. They can explain why someone has been falling. They can reveal why memory suddenly seems worse. And sometimes they can stop a serious medication problem before it becomes a hospitalization, a fracture, or a permanent loss of independence. So here is the final takeaway. After 65, common medications can become uncommon dangers. Sulfonylureas can lower blood sugar. Oral NSAIDs can damage the stomach and kidneys. Z drugs can turn a night of insomnia into a devastating fall. Antipsychotics can carry serious stroke and mortality concerns in the wrong setting. And benzodiazepines can combine brain slowing, dependence, and deadly interaction risk in one widely used class. If you are over 65 or you care for someone who is, this is your reminder to look at the medicine cabinet with fresh eyes. Not fearfully, wisely. Because sometimes the most life-changing health decision is not adding a new prescription. It is recognizing that an old one has quietly become the new problem. I'm Dr. Leana, and if this video helped you, tell me in the comments which medication you want me to cover next. Share this with a parent, spouse, sibling, or friend over 65, because one careful medication review can prevent a fall, an ER visit, or something far worse. And subscribe for more clear, science-based guidance to help you stay stronger, sharper, and safer as you age.